Insulin basics. The school nurse, when available, is the most appropriate person in the school setting to provide care for a student with diabetes. However, many schools do not have full-time nurses. Even for schools that do, the nurse may not always be available at all times during the school day, during school-sponsored extracurricular activities or field trips to assist with routine care and emergency care. Trained school personnel must be available to perform and assist the student with diabetes care tasks. This presentation is not intended to provide legal or healthcare advice. Please consult with a legal or healthcare professional regarding your specific questions or needs. Each training component was created specifically for school nurses and other qualified healthcare professionals to train school personnel. This unit is Insulin Basics. The objectives are for participants to be able to understand what insulin does, the types of insulin delivery methods, storing insulin, and factors that influence insulin dosing. School personnel responsible for performing diabetes care tasks or assisting with the student's diabetes care task should know about and be trained in using and operating each student's insulin delivery system. In the event a school nurse is not available to administer insulin, the nurse or another qualified healthcare professional should teach, monitor, and supervise trained diabetes personnel to administer insulin. School staff who will perform or assist students with insulin administration should understand how insulin works. Let's review a few vocabulary terms. Target range, a range of numbers that represents an individual's ideal blood glucose level. This is determined by a healthcare team with the individual child with diabetes and the parent and guardian. Everyone's blood has some glucose in it. In people who don't have diabetes, the normal fasting range is about 70 to 100 universally. The American Diabetes Association sets guidelines for normal and abnormal blood glucose levels. However, each person's target range is determined individually by his or her healthcare team and parent guardians. Young children with diabetes may have slightly higher target ranges than adults with diabetes. And those starting out on an insulin pump therapy or are newly diagnosed with diabetes may also have higher target ranges to help avoid hypoglycemia. Basal insulin. Sometimes this is called background insulin. This is the insulin that's working steadily throughout the day. Basal insulin may be provided by injection with either long-acting or intermediate-acting insulin, or by continuous infusion of short or rapid-acting insulin with an insulin pump. In diabetes treatment, the term basal refers to that low amount of insulin that is always needed to cover the basal metabolic functions of daily life, such as breathing, heart rate, and other functions. Bolus insulin. This is a single dose of insulin given for one of two reasons: to cover carb in meals or snacks, and for correction doses. Years ago, few students with diabetes took insulin injections at school, but now many physicians prescribe intensive insulin therapy for children that requires multiple daily administrations or injections to enable students to maintain blood glucose levels within the target range. This is because studies have shown that intensive treatment can prevent or delay long-term complications of diabetes. Today, many students will take insulin at lunch, during their food intake, or when blood glucose levels are above target range. Regardless of when they need to take insulin, many students will need accommodations to ensure timely, accurate insulin dosing. Most older or more experienced students are capable of self-administration, although some may want a private place to administer their insulin, or they may require supervision. Others will need full assistance in drawing out, dosing, and blousing or injecting. Insulin dosing and timing will be specified in the DMMP. These physician orders may include provisions for the parent guardian and/or capable students to modify dosing. How, where, and who may perform or assist with insulin administration is determined jointly by the parent guardian, student, school nurse, and other school staff, and should be documented in the Individualized Healthcare Plan, or IHP, and the student's 504 plan, IEP, or other written accommodation plans. Insulin is a hormone that is needed to convert sugar, starches, and other food into energy by moving glucose from blood into the cells. Students with type 1 diabetes do not produce insulin. Their beta cells, the insulin-producing cells of the pancreas, have been damaged or destroyed. Without enough insulin, students will experience both short and long-term complications. They will experience low energy levels, feel listless, become dehydrated, and could become severely ill. Without any insulin, they will become severely ill within hours, and if left untreated, could result in death. Historically, many but not all students took their insulin by using a vial and syringe. An increasing number of students are using other methods, especially pens and pumps. Insulin pens offer the convenience of carrying insulin in a discreet way. An insulin pen looks like a pen with a cartridge. Some pens use replaceable cartridges of insulin. Other pen models are totally disposable. A fine needle, similar to the needle on an insulin syringe, is placed on the tip of the pen. Users turn a dial to select the desired dose of insulin and press a plunger on the end to deliver the insulin just under the skin. There are two types of insulin pumps. The pump that has been in use for a number of years is about the size of a pager, weighs about 3 ounces, and can be worn on a belt or in a pocket. The pump connects to a narrow, flexible plastic tubing that ends with a needle or cannula inserted just under the skin in the abdomen, buttocks, or thigh. Users set the pump to give a steady trickle or basal amount of short or rapid-acting insulin continuously throughout the day. Pumps also allow the user to deliver bolus doses of insulin at meals and at times when blood sugar is too high based on the user's programming. The newer kind of insulin infusion pump is often referred to as a patch or pod pump. It differs in that it adheres directly to the body without using additional tubing. It is a disposable unit that is controlled by a separate PDM device or smartphone application. Here is an illusion of insulin release in an individual without diabetes, and in the background, an approximation of insulin delivery in an individual with diabetes, receiving multiple daily injections. This treatment regimen allows delivery of greater amounts of insulin when needed to address the glucose-raising effects of mealtime or to correct elevated levels while providing the background insulin needs of the body at rest. Insulin pump therapy allows for more precise insulin dosing at meals and corrections, and the ability to better accommodate variations in the background insulin needs affected by factors such as physical activity and stress. The graph on this slide represents the action patterns of insulin types in use today. The intermediate and long-acting insulins provide basal insulin concentrations and doses are adjusted based on the student's pattern of blood glucose. They are not used for acute treatment of high blood glucose levels and are not generally given at school or before meals. Intermediate and long-acting insulins are referred to as basal insulins. Basal insulins control the blood glucose in the fasting state when you're not eating. Basal insulin is typically 50% or less of an individual's total daily insulin dose. Rapid-acting insulins act quickly within 10 to 15 minutes and are used primarily to treat high blood sugar levels and to match or cover the rise in blood glucose levels that follow food intake. Many students require rapid-acting insulin before meals and snacks. Note, hypoglycemia or low blood sugar can occur if a meal or snack is delayed greater than 15 minutes after injecting of rapid-acting insulin. Rapid-acting insulin is frequently referred to as bolus insulin. Rapid-acting insulin is also used in insulin pumps. Short-acting insulins are used like rapid-acting insulins, but have a longer onset and duration of action and a delayed peak. Short-acting insulin is also referred to as bolus insulin. The shelf life of insulin after opening varies according to the type of insulin, the type of container, whether it's a vial or a cartridge, and how insulin is used, whether it's in a pen, a cartridge, or a pump. Review the product storage instructions on the manufacturer's package insert and check the expiration date on the package for specific information. In general, most open vials of insulin may be left at room temperature, below 86 degrees Fahrenheit, for 30 days. Most open disposable pens or pen cartridges may be left at room temperature for less than 30 days, depending on the type of insulin and the type of pen or cartridge. Unopened vials should be stored in a refrigerator and are good until their expiration date. Insulin must be administered as specified in the student's DMMP. The DMMP specifies the orders of the student's health care provider. The DMMP should clearly specify insulin dosing procedures. Generally, students will only need to administer their rapid-acting bolus insulin at school. Their basal insulin will be delivered at home in the morning and or evening or throughout the day by an insulin pump. Generally, bolus insulin, either rapid or short-acting insulin, will be given before meals or some snacks, depending on the DMMP recommendations, for blood glucose levels significantly above target range, and for moderate or large ketones. Insulin works best when it is injected into a layer of fat under the skin above the muscle tissue. Rotating sites is important to insulin absorption. Common preferred sites are the abdomen, thighs, buttocks, and upper arms. Students should help choose injection sites, but should be guided away from lumpy, scarred, or bruised areas. Many students will take rapid or short-acting insulin at meal or snack times. Some students will take the same dose regardless of blood glucose level or food intake. Doses for many students, though, will vary. For those whose doses vary, it is important to understand the two concepts of carb or meal boluses to cover what is eaten and correction boluses to cover high blood glucose. These two concepts are covered in the next two slides. Most students who vary their dosing at mealtime will do so using an insulin to carbohydrate ratio. The insulin to carbohydrate ratio varies from student to student and may vary from meal to meal. The DMMP specifies how much carbohydrate that each 1 unit of insulin will cover or match, calculating the insulin to carbohydrate ratio. For example, a common ratio is 1 to 10, usually stating 1 unit of insulin per 10 grams of carbohydrate. To calculate for a meal that contains 60 grams of carbohydrate, with the ratio being 1 to 10, we would take the 60 grams and divide it by 10 to get 6 units of insulin for the correct dose. The correction bolus is the amount of insulin to correct a blood glucose level above the student's target range. Once again, this will vary from student to student. It may be stated as a stepwise correction dose or a sliding scale, or may need to be calculated using a formula to determine the dose. The DMMP will specify if, when, and how correction boluses are to be determined and given. For the sliding scale, correction doses are specified at specific blood glucose intervals. For example, a student may need 2 units for blood glucose from 150 to 200, 3 units for 200 to 250, and 4 units for blood glucose greater than 250. Correction doses are calculated by subtracting the target blood glucose from the actual blood glucose. Then the difference is divided by a correction factor to determine how many units of insulin are needed to lower blood glucose to the target range. For example, consider a student whose blood glucose level is 150 and the target is 100. If the correction factor is 50, this means 1 unit of insulin would be given as a correction dose to correct for high blood glucose. For some students, dosing at mealtime may include both a carbohydrate dose and a correction dose for blood glucose that is above or below the target range. In this case, the total dose would be the carbohydrate dose plus the correction dose. If the student's blood glucose is below the target range, the correction may mean giving less than the usual dose. Students whose dosing accounts for both carbohydrates and blood glucose are more likely to need assistance from school staff. Many insulin pumps will automatically calculate the correction dose when blood glucose levels and carbohydrate intake are entered into the pump. A few pointers to keep in mind after insulin is given, regardless of whether it is by syringe, pen, or pump. Occasionally, injection sites or infusion sites will leak when insulin is administered. Document on a log sheet. When correction doses are given to lower blood glucose, a retest should be done, if specified in the DMMP, to determine how well the correction dose worked. Ideally, mealtime insulin should be given prior to eating the meal or snack. When insulin has been given prior to eating, it is important that the food is eaten soon, beginning within 15 minutes after the insulin has been taken. If necessary, the student should be moved to the front of a long line or given milk or juice or some other quick-acting carbohydrate. This should be included in their carbohydrate coverage dose if the student is not hypoglycemic. Younger students may need to be supervised at every meal snack to be sure the amount of food eaten is appropriate for the insulin given.